You should be the director. You should be like, cut. Okay, so if somebody's got too much growth hormone, right, what kind of presentation is the patient going to present with?
Acromegaly.
So it depends, right? If it was a kid, you will have gigantism. But if it was an adult, you're going to have acromegaly, right? So whenever it comes to boards, we are really going to be dealing with acromegaly, not gigantism. Why? Because we are internal medicine, we deal with adult medicine. So they are going to go after acromegaly. So what are some of the features you'll actually have with the patient with acromegaly?
Large hands.
Large hands, okay.
Big chin.
Large hands.
The jaw.
Big jaw. What is that called? Huh? Prognatism.
Prognatism.
And then
Prognatism.
forehead.
Frontal bossing. Okay, what happens to your tongue?
It enlarges.
What is that called? Macroglossia, right? So the reason they don't grow tall is because your bones, everything's fused already, so you can't grow vertically, so everything starts to enlarge like this. Now these are just the clinical features, but there could be a bigger problem that's happening to patients with acromegaly. What is that?
Cardiomyopathy?
Yes, you can actually have heart problems. So these are features, but what big problems can they develop? One of them is going to be hypertrophic cardiomyopathy. Okay, what else can happen? Imagine they have a big tongue and it falls back on them when they go to sleep. Obstructive sleep apnea. Okay, obstructive sleep apnea. What else can they get? Hypertension. Okay, they can have hypertension. Is it important to do colonoscopies on patients with acromegaly? Since I'm asking, probably the answer is yes, because it actually increases the risk of colonic polyps and colon cancer. What does it do to your thyroid gland?
Enlarges it.
It actually causes increased risk of thyroid nodules and thyroid cancer. Okay, so board probably knows that you know the clinical features, but what they are going to go after is the problems that can actually happen with these patients. Hypertension, obstructive sleep apnea, okay, hypertrophic cardiomyopathy, colonic polyps, colon cancer, thyroid nodules and thyroid cancer. It actually increases their risk of all these conditions. Best initial test is going to be IGF-1, insulin-like growth factor 1. That's what you're going to check for, right? Okay. When it comes to acromegaly, your gold standard treatment is going to be transsphenoidal surgical resection. But for some reason, if the patient is not a good surgical candidate, then you can actually treat them with medication. And what's your medication is what you're going to give. What is your drug of choice? You're right. It is somatostatin analog, which is what? Octreotide. Yes. Any other tides you all know of? Lanreotide. Octreotide, lanreotide. So somatostatin analogs becomes your first line treatment when it comes to medications for the treatment of acromegaly. Yes? Okay. Any other drugs we can use? So once you do the treatment, are we going to follow patients' IGF-1 with time to make sure there's no remission?
No.
Yes, you have to. You have to follow IGF-1 levels once you start treatment, whether it's surgical, maybe it be medical, because they can always have relapses. Okay, so you want to follow. And once the IGF-1 is actually gone down and you've attained remission, okay, once you've attained remission, does that decrease your risk of hypertrophic cardiomyopathy, colon cancer? Yes, it does. It actually does. That's why it is so important to actually follow and make sure you go into full-blown remission from these patients. Thank you for watching. If you like our content, please like this video, subscribe to our channel and hit the bell icon so you get notified when a video is released every week. Have fun studying. We'll see you on the next one.